What is up, YouTube? It's Dr. Caesar. I'm back to talk about epidurals. Uh, the epidural is a procedure that's commonly performed, especially in labor and delivery. It's the way that we deliver the most common anesthetic on labor and delivery for in terms of anesthesia. And there's also a lot of mystery behind it. There's just not a lot of good educational videos just showing exactly what the procedure actually is. So here I have a video and sort of a step by step on how we place epidurals and what it looks like. So the first thing we're gonna do is I'm just gonna play the video and then I'm gonna talk about after, sort of take you by the steps. All right, so here we go. It's a two-part video. It's about a minute total, but here's the first part. So when placing an epidural, what we're achieving is essentially threading the catheter into the epidural space. Now what you want to do is identify your midline, and what we do is we're feeling the back here for bone. And that's analogous to feeling this structure here, the spinous process. You can use your local needle to identify midline, which would be the superficial bone here that you can feel on the back. Now, if you're injecting and you don't feel anything, you're probably not midline. You can use your local needle, numb the patient, and then identify your midline, which here we can identify our midline. So now what we're going to do once we've identified midline is go a few centimeters above and inject our local into deeper structures. Now you do want to make a nice skin wheel, make sure the patient doesn't feel the rest of that. You want to keep your fingers there because you've already identified midline, and you go in the same place a few centimeters above, and you want to introduce your needle until you feel some resistance. All right. There you go. Part two right here. Just a continuation of that. You feel some resistance, and that's when you know you have engagement with ligaments. And your needle should look like this. Otherwise, it would be too floppy and you're probably too superficial. Now, you want to use saline in your syringe. You make a nice lock, and about 50% of the pressure is going to be on your hand here, and about 50% as you're advancing. And what you want to do is advance until you have a nice loss of resistance, which is indicative of being in the epidural space as you pop through the ligaments and phlegm. So I'm advancing and holding pressure. Again, 50% pressure here, 50% up front. I'm going to advance until I have a nice loss. And there, I have a nice loss. We can see it here in our needle, in our syringe. You gently unscrew, and this is where you thread your epidural catheter. What's really important is as you thread, you want to make sure that you're stabilizing your hand on the back. It's similar to advancing a wire as you're placing a central line. All right, so that's sort of the straightforward approach into placing an epidural. But again, and if you've seen other educational videos that I've made, it doesn't really mean much if there's not an explanation behind it. So what I'm going to do is sort of take you step by step so you really understand, have a sort of comprehensive um, understanding of the epidural technique. Okay, so let's see, we'll get these back up. Okay, I'm going to move my screen just for a second here. All right. So what we have here, again, Wikipedia use really high resolution images, good stuff. So this is an example of sort of, we start with our anatomy, right? Everything is, you got to break things down into their basic forms, and everything starts with anatomy. A lot of my mentors, a lot of doctors teach medical students, residents, that if you don't understand anatomy, you're not going to get the basics of medicine, of practicing medicine, especially in a field where you do a lot of procedures like anesthesia. That's what I do, or intensive care unit, or whether you're a surgeon, whatever it is, you have to know anatomy. So this is the spine, and imagine, this is the back of the patient, and the abdomen is over here. And these bony processes are called the spinous process. And you really want to go in the middle. So we're using the needle to go in the middle, and then we're going to identify or we're going to create a space that's called the epidural space, and we're going to put our catheter in there, that thin little wire that you saw. Okay. So this is a pretty cool depiction. So again, the image is flipped, but this is where the needle is coming through here. If you could just kind of imagine my mouse cursor over here. All right. So now this is the catheter, or the wire. I call it like a thin wire, and this is your needle, and you want to go between the bone, and then when you approach, right, you're going to go through, and this is all tissue, right? So you're going to have some sort of, imagine just a needle going through tissue. It's going to feel a little kind of tough, right? So after you have, put your local anesthetic on the numbing medication, you place your needle, and then you're going to find this space here. It's called the epidural space. But look how much, you can just imagine if this is pretty close to sort of human kind of size at this, if you're opening up like on a regular screen. But you don't have a lot of room, right? So a lot of this is just things that you feel. So once you approach the epidural space, you're gonna have sort of like a loss, or you're gonna have a give in your pressure. So you have a lot of pressure as you're going through these ligaments here, and then boom, you're gonna lose that pressure, and that's when you approach the epidural space. And that's really important because there's another video that I have on here about doing a surgical airway, a needle cricothyrotomy, and it's also by feel. A lot of this is just through routine practice, the way you get that feel. And I always make I like sports, so I make the analogy to sports. It's like an NBA player making free throws. The more you do, those players that have the high percentage, they practice a lot. Steph Curry's of the world and stuff like that. This is from a different angle, but basically needle is going through the spinous process, and again, you're approaching this space called epidural space. This is your sort of pump. And again, these images are from Wikipedia, and these pumps are programmed to deliver anesthetic usually at a continuous rate, meaning that it just continuously going, or it's giving medications in a sort of pre-programmed infusion. Okay. Those are all our images there. Okay. So now that we've sort of, have our background, I'm going to talk about the procedure. I'm going to talk about the video, but in a bit more sort of step-by-step fashion. So what I'm doing here, you have your kid. This is a sterile procedure, obviously. And then this is just, again, educational, your own institution, your own residency, your own professors, mentors may tell you to do this a different way. This is how I train. This is kind of the style that I perform epidurals in. So what I'm doing is I'm feeling the back, right? So I'm feeling for that spinous process, that bone, that prominence, right? And so, imagine if you're putting something in what you have skin, you have to imagine where you're going, and one good way of imagining is by feeling. But there's a degree of an art to it. So what I'm doing there is, that's a local needle. It's they come in really small gauges, meaning they're just a really small diameter needle. So what happens is when you are numbing the skin, you can sometimes find that spinous process, and your midline. So that's the spinous process, and you want to go in the middle, right? So that you could see right there that it was kind of, that the needle was kind of, I hit something, right? But that's the spinous process. So I know, and I keep my finger there, so I know that I just have to go a few centimeters above and inject. So that's what I'm doing. So that's all just the numbing medication part. That's part one. And then this is your actual needle where you're going to thread your epidural through. And depending on the institution you're at, they're all sort of the same. They're much bigger needles, so you really, this part of the procedure, the patient should be really numb. But there's some variations in the type of needles. So you want to advance at that midline point. So that's exactly where, I'm in the middle, right? We have part two here. right? You feel some resistance. So in the video, I say you feel some resistance, and you guys notice how it's just kind of hanging out there. So the needle is just staying there like that, right? Why is it not moving? Why is it not flopping out? That's important, right? Because that sort of lets you know that you're here. Because remember, you don't have a lot of real estate to work with, but that lets you know that you're here. You're somewhere in these ligaments, okay? And that's important because when you're engaged, right, as soon as you feel that sort of firmness in your needle, you know that you're getting close to the epidural space. So that's where most people stop, and they're like, okay, I've introduced my needle, and now I need to go a little slower. And that's the point. That's what I'm saying here is like, it feels like I engaged. So right there, I didn't introduce that much. Just introduced a few centimeters. So just a few centimeters, and then I know, okay, now that I engaged, I know that I'm getting close. Now you don't want to go too far because you could pop into um, a different layer that's called the dura, which is painted here. And if you pop in there, then you cause what's called a dural puncture, and that's where the headache comes from. The 1% risk or in some studies even shows less than 1% in terms of causing a headache. So you introduce very superficially, just 2-3 centimeters, and you know that you're not that you're engaged in ligament. And now what I did, and this is an important step, I have my glass syringe, right? And my glass syringe I fill with saline because when you're sort of creating this pressure in that glass syringe as you're advancing, and when you pop into the epidural space, so we use the term pop, or when you find the epidural space, you're going to have a loss of resistance. You're going to essentially create, so the epidural space doesn't really exist, so to speak. It's you create the epidural space. It's a false space, but you create it with most people, I would say, use saline. There are some people out there that use air, but you're creating this potential space, and it's when you pop into a ligament called the ligament of flavum, which is like this tough sort of ligament. And once you pop in, you're in the epidural space. So you're creating, and right here you can see it. You're in the epidural. So that's a ligament. You can see that little white line right here. That's a ligament. And boom, you pop in, and you're in the epidural space. So it's a procedure by feel. So I have my saline, and then what I'm going to do, and I have someone helping me here with this is a little mini mannequin. What you're going to do is you're going to advance, okay? And a component of my pressure, about 50% of my pressure, I was always, sort of trained to, okay, about half of your pressure is going to be here, half of the pressure with your needle, or you could just advance, which is called just like a slow advancement, and you're checking. So this is more of what's called a continuous style. So I'm advancing very slowly, and I'm getting close. So I'm approaching this right here, right? I'm approaching the ligamentum. I'm getting close, and then you're going to see my syringe just loose. I'm just going to pop into that epidural space right past the ligamentum, and you're going to see, or when I pop through the ligamentum, you're going to see, I want you to pay attention to the syringe here as I lose the resistance. Right there. So it's very subtle, right? And I'm injecting the saline in. Saline is it's not a toxic fluid, so it's that's sort of the universal go-to fluid that we use, normal saline. So now this is hollow. So this is our epidural catheter. It's a little thin spaghetti kind of noodle looking catheter. So I pop in, and your needle is hollow. So now you have to work sort of efficiently to thread that catheter. So at this point, you grab your, there it is. It's a catheter right there, very thin. I mean, it's just kind of floppy. And the needle has centimeters, so you know exactly how far you're going in. And I'm going to show the end of it here, but what happens, you just thread it and you take out your catheter. You take out the needle. So that's basically in a nutshell. And that took me, in the right hands, with someone experienced, someone could place an epidural. I mean, a lot of the process is you sterilizing the back, but you could place an epidural in a few minutes. Um, but there you have it. It's more of a just educational. What is how the epidural? How are they? What's the anatomy behind it? Um, I'm certainly not going into the types of medications we use or any other, you know, uh, aspect of the epidural. I mean, this is something you can spend hours and hours of time on. This is just a procedure sort of to show you, for those of you that are medical students, there's a lot of implications here with anatomy. I mean, you guys all learn anatomy. For those of you that are residents, it's hard to understand the new procedure without seeing it. That was my problem that I had. I was like, I need to see things. I am a very visual learner. Like when someone would teach me an intubation as an anesthesiologist, I'm like, well, I, I need to feel what it's like to intubate someone. I need really good, high quality videos. And those didn't exist back when I was a medical student. You couldn't go on YouTube and find those videos. So I hope that this is able to provide a level of basic education. And again, everyone has their own styles. This is just my style. This is something that I practice, that I've adapted with time. If you guys have any questions, feel free to ask. All right, and thanks for your time.